Welcome to another episode of K&K Real Talk. Today I have Dr. Sinervo with us. So I'm so excited to have you. Why don't you tell our viewers a little bit about yourself?
All right. I'm originally from Canada. You moved to the United States to do my fellowship in advanced laparoscopic surgery. I joined the Center for Endometriosis Care in 2001. And in 2010, I took over as the director of the center. And, we have a new physician on board as well, Dr. Arrington, who's been doing endometriosis for about 13 or 14 years as well. And so, the Center for Endometriosis Care is one of the premier centers for excision of endometriosis, and if not the country, definitely, and maybe even the world, because we're getting patients from approximately 60 other countries, as well as pretty well every state in the country as well.
Wow, so you must be very busy.
Yeah, we're pretty busy. I operate 4 days a week, do about 350 to 400 cases a year.
Wow, it's crazy. Do you work with any other surgeons in Canada or in the United States?
We don't work with anyone, any other groups per se. We do collaborate with other physicians at our hospital. We approach endometriosis in a multidisciplinary fashion. So what that means is, we work with other specialties, for example, urologist or general surgeon or thoracic surgeon, so that we can deal with every different aspect of endometriosis that would come up, okay? So as you know, there's definite involvement of the bowel, bladder, ureters, and the chest in terms of endometriosis. Those are kind of the more common areas outside the reproductive organs that are involved. So we have to have a team that can address all those different areas of concern, okay? And we try to do most of our surgeries, do everything that we need to in one surgery so that we can minimize the cost of the patient of having to come to Atlanta for several trips. And that way we're able to, deal with bowel endo and thoracic endo at the same time, or deal with whatever's going on with their bladder and ureters at the same time as dealing with whatever may be going on with the reproductive organs as well. So by doing that, we have the best outcomes in terms of the amount of recurrences that we have, as well as the percentage of patients that are significantly improved in terms of their symptoms.
Endometriosis is really a whole body disease, and I love that you focus on more than just reproductive organs and making sure that they're okay. I mean, it's everything. There's nothing in my life that I can't think of that's not affected.
Oh, absolutely. Some of the posts that have recently come up have had to do with, chronic fatigue being a big issue in patients who have endometriosis. And part of the reason for that is it is a systemic disease. We don't know the exact role that the immune system has in terms of, how that plays into endometriosis, but we do feel that it's an autoimmune mediated disease. And because of that, it can affect patients sometimes, complain of fevers or, just fatigue is very common. And, as I have always described to my patients, probably one of the main reasons that they're having fatigue is that not only because it's a systemic disease, but also because if they're in pain all the time, it takes energy to fight pain. Your body is always tensed up, and it's, it's like you're in a constant battle, literally. And, with that, amount of adrenaline and tension in your body, you can imagine how, most patients come home if they're having a lot of pain and they just get home and they just crash on the couch and they feel like they can't do anything. Really, they are able to function for 8 hours and that's it.
I totally feel like that. It's like the spoon theory. You have an allotment of energy for the day and you use it, it's gone.
Yeah, absolutely. Yeah, and I kind of have a joke about that. With guys, the thing is, they've only got like 2,000 words that they use, and by the time they get home, they've only got 50 left. For their significant other. Same sort
Definitely.
of thing, but you guys use up all your energy with your pain and dealing with that.
I definitely feel like that.
Yeah.
So my first question is a topic that's been coming up a lot in groups on my page. Lots of people are asking me about the new drug that was approved by the FDA. A lot of people are saying like it's an oral Lupron. What's your opinion about the new drug?
Okay. Well, Orlissa or Elagolix is it's slightly different than Lupron in terms of how it acts. Okay. Lupron is a GnRH or gonadotropin releasing hormone agonist, and Orlissa is a GnRH antagonist. The bottom line is they both end up blocking the receptor and causing a menopausal state. Okay, so the patients will often have a lot of the same side effects that you would have with menopause. So they have hot flashes and night sweats and bone density loss. And so a lot of overlay there in terms of the types of symptoms that they have. One of the big things that unfortunately does not get a lot of press is the fact that about 25% of patients in some of their studies drop it out. And that's a really high dropout rate, okay? And so they don't really account for that. They'll have the percentage of patients that dropped out for a particular reason. They'll say, okay, yeah, they had hot flashes or night sweats or headaches that were too bothersome and they dropped out because of that. But there's a lot of dropouts that they don't account for in terms of what particular side effects they had. And so that's one of the unfortunate things about that. The other thing is there's some more serious potential side effects as well. One person actually committed suicide in the studies out of 1,000, just under 1,000 patients in the study. And they do mention that. They do mention suicidal ideation as one of the side effects. Unfortunately with Lupron, there weren't a lot of long-term follow-up studies either. And it's only recently that they've been tracking more and exposing more of the side effects that have become more chronic, such as joint pain that never goes away or memory loss that doesn't seem to improve. One of the things that Dr. Redwine has mentioned as well is possible decreased ovarian function, where the ovarian function doesn't return to normal in some patients. And these types of things are highly unpredictable and they're not as common, but at the same time, they're very serious side effects. Another thing is that over 1,000 people on Lupron committed suicide, which is also something that has only recently come out with the longer term follow-up studies. And so that's another big thing. I don't know how many patients have ever been on Lupron, but I'm sure it's millions. But still, 1,000 patients committing suicide is a significant number.
That's a huge number.
Yeah.
I didn't know that part.
Yeah. Well, and there's definitely a certain number of patients who commit suicide with endo. Otherwise, on all the different boards that we're on, we always hear every now and then of someone who unfortunately, tragically commits suicide just because they feel that they're at a hopeless point in their life, dealing something that seems to be chronic that they've never gotten any relief from. And that's a terrible blow to the community for sure, and to all those other girls out there who are trying to fight against the disease.
And that's one of the reasons why I try to be so positive and put a positive spin on having endo and telling them that there's things you can learn and you can still live a life. Maybe it's not the exact life that you wanted to live, but you can still live a fulfilling life with endo. I mean,
Absolutely.
I'm still in pain every day, but I try my very best to do the things that I love and try new things and live like I would have without endo. But I know my limits and I play within it, kind of thing. So
Yeah.
everyone needs to learn their own personal limits.
Yeah. Well, and one of the other things is, unfortunately, a lot of people don't have the opportunity to have the best type of surgical, surgery performed on them. Okay. You know, I'm a big believer in excision. Okay. We excise every lesion. We don't ablate anything. And that maximizes our chances that our patients are going to be pain-free. When 85 to 90% of our patients have significant improvement in their symptoms, and despite that, most of them have had 3 or 4 surgeries already. They've been on 3 or 4 different medical treatments. And despite those findings that, they've already failed all these other things, 85 to 90% feel better, okay? And the percentage of patients who, if you look at all the patients that we operate on and the percent that are found to have endo again in the future is less than 5%. So, I definitely feel that from a, elimination of the disease. And again, we never say that it's a cure because, again, it's a systemic disease. But if we can get rid of most of their pain triggers, then they can, get at least some improved quality of life, if not a significant improvement in their quality of life, where they're able to, plan things again and be able to, do the activities that they really want to do. A lot of doctors say, well, endo's not going to kill you, right? It can from a suicide perspective. But yes, in general, it's not a deadly disease because it isn't going to kill you directly, but indirectly it can. But it basically destroys your life and you have no quality of life. And so that's really what I think that, ourselves and other excision doctors try to do is restore that quality of life so that you can actually enjoy living again. And, every week, I get a message from someone who's had a 10-year anniversary or a 3-year anniversary. Today I just had one from a patient 3 years. She's been pain-free. She elected to adopt a child or have a surrogate in India and have a baby there, and she's got a great quality of life. And we get those types of follow-up emails all the time. And so that's why it's so rewarding to be able to do that and restore the quality of life back to these people. And just spreading that is so important so that other people can realize that, yeah, there is hope out there. The great majority of the time we're going to be able to get patients feeling a lot better. And still, for the majority of those patients, do it in a conservative manner or keeping most of their reproductive organs.
Is there anything that you recommend after having excision surgery? Like, do you recommend following a certain diet or making diet changes or any sort of certain exercise, anything like that?
Well, exercise is a very important part of any lifestyle, right? So, definitely encourage that. A lot of patients who have a lot of pelvic floor issues and other, musculoskeletal issues, they, often benefit from things like yoga or Pilates because, those are kind of almost an extension of the physical therapy that a lot of them end up doing. Okay, so yes, I definitely recommend that. I recommend, a healthy diet, and you can do it with an anti-inflammatory diet. I'm not a big fan of the original endo diet, which came out, 20 years ago, where there was only about 30 things that you could eat on it, because most of the patients who are on it never stayed on it, and they ended up coming off. But, nowadays, I think there's a bit more of a lean towards, a diet that has low inflammatory things in it, so eating organic foods, avoiding gluten, which, in 10% of patients, they may or may not have celiac or gluten enteropathy or just gluten sensitivity, where they're going to have less bloating from that. Same thing with lactose. If you come off of lactose for a month and you notice an improvement, I suggest, okay, just staying off of that. And 10 or 15% of patients are going to have just a really big improvement from that alone. Okay, and then just having an omega-3 fatty acid in your diet is very important, because that's basically what makes up the cell membranes in our body. And by having a good amount of that and preventing our diet from having a lot of omega-6 fatty acids, which tend to cause inflammation, those are the types of things that we really want to avoid. You can definitely add things into your diet like turmeric, which is an anti-inflammatory, vegetable and spice. And then things like ginger as well, which is anti-inflammatory, maybe, good with like ginger tea or using ginger in a lot of the foods that you cook. Those are some of the important things. I think most patients should have a multivitamin because there probably are a lot of things in our diets that we don't necessarily get, and that just kind of, especially when we are eating certain diets, we're probably going to miss out on some things. I don't think that there's any one particular diet out there that's going to be best for all patients. But I think if you follow those rules, you try to, to minimize the amount of inflammation, you may want to eat organic food. So organic chicken, organic beef, and then organically grown vegetables and fruits, so that you have less of the, toxic things inside of those as well. Because, we don't really understand how much that affects our bodies as well. So yes, from that perspective, those are the types of things that I recommend. In terms of other lifestyle things, mindfulness is very important, so, considering meditation may be helpful for some patients to deal with pain and kind of redirect their energy to positive things, away from the negative things as well. And physical therapy for the patients who need it, especially pelvic floor physical therapy. We really didn't even know how bad the problem was until about 12 years ago, 15 years ago, how big an impact pelvic floor dysfunction was. And once we realized that it was a really big issue in terms of the success of getting patients pain-free, we realized that there are a lot of patients who have some element of pelvic floor dysfunction. And so recognizing that, it may be as much as 30 to 50% of patients have some element of pelvic floor dysfunction. And so even a short course of 8 or 12 weeks for most of it, that's all they really need. Others may require longer term physical therapy to kind of get that under control. But the great majority of them, within a short period of time, will have significant improvement.
Awesome. So what would be something that you would like to see more of in the endo community?
Well, awareness, that's really the biggest thing, I think. If we, one of the things that I'm involved in is the Endo What movie, and they're coming out with the second one this spring, I believe, which I think it's a little bit different from the first one. It's really following the lives of 5 different endo patients, basically for about 4 or 5 years. A couple of those are patients that I've operated on. So it does follow those patients along in their struggles and to some extent their triumphs as well. So that is a very important kind of grassroots thing. And that what Shannon is trying to do with that is she's trying to increase awareness at the, grade school, middle school, high school level. If we could eventually have that video in every high school or middle school in the country, that would be huge, because then young women themselves would realize, hey, what I'm feeling is not normal. And the biggest problem that we have right now is the delay in, there's really 2 or 3 really big problems. One is the delay in diagnosis, okay? You're probably aware that the delay is anywhere from 9 to 12 years, depending on the study that you look at, which is ridiculous. How many other diseases are there out there that takes that long to get the diagnosis, okay? There was a study in, I think it was Denmark a couple years ago, that showed that they could actually get that down to 2 years if doctors were a little bit more open to the idea that, having, periods that have you in a fetal position are not normal, okay? And so we can definitely get that down to a much shorter period. One of the problems that a lot of girls have is, they'll mention it to their doctors and their doctors will blow them off. And they'll say that, well, sorry, hon, that's normal, just suck it up, and mothers and other family members can be that way too. It can be very hard to get the support that you need emotionally and in terms of trying to get that diagnosis at an early age. But if you recognize that and you put someone on birth control and they're still having pain after 6 months, there's no benefit in any of the literature to support trying another type of birth control. Okay, there's nothing in the literature to support that. And then there's nothing in the literature to support using other things that have a lot more side effects, like Depo-Provera or Lupron or other progestins, or definitely Orlissa. You know, when you've got a $15 a month birth control pill with your copay, and you've got an $800 Orlissa, which has not been shown to be probably any more effective than birth control, okay? Its indication is for a treatment of endometriosis-associated symptoms or pain, okay? And some doctors argue that, well, birth control is not indicated for, treatment of endometriosis. Well, yeah, there's a lot of things that we use in medicine that aren't indicated. That's, basically what they're saying is the FDA did not approve it for that indication, okay? But there's hundreds of studies that have shown the benefit of birth control as the first or second line treatment of patients with endometriosis. So a lot of them are going to have improvement of it. And, not all pain that women have, even once they've been treated, is necessarily related to their endometriosis. Some patients may still have pain from their uterus. Some patients may have painful ovulation. And so, those are often the reasons that we end up having to put patients on other things afterwards, not necessarily because of their endo per se. So if we can get early diagnosis, what we can do is we can get patients having more effective treatment. And by effective treatment, I really, again, I'm going back to excision, because ablation is not a very good form of treatment of endometriosis, okay? What happens is 60 to 80% of patients have recurrence of their pain within 1 to 2 years. And so what happens is they end up having multiple ineffective surgeries that just really delay the best surgical treatment, which I feel is excision. And most of the endometriosis experts in the world, I think, feel that excision is the way to treat endometriosis, especially advanced stage disease. Cauterizing a nodule that's a centimeter thick is not going to get rid of that disease. There's no way that it's going to get rid of that disease. And you can't use enough electrical energy to get rid of that disease without worrying about damaging everything else in the pelvis. So excision is really the keystone to the treatment of endometriosis, and getting more doctors who are very good at it. And there's a high variability in the skill and the success of doctors performing excision. And there's a lot of doctors who are probably great at treating, mild stage disease or even moderate stage disease, but there's probably not many out there that are really good at treating the worst disease out there, like this really bad stage 4 cases with bowel disease and ovarian disease, the disease in the pelvic sidewalls. So one of the problems that we also see when their patients are having ablation done is that we almost change the pain condition that they're having. So sometimes they're no longer having pain from their endometriosis. They're actually having pain from the damage that we've caused under the surface, or the retroperitoneum. And so a lot of these patients end up having damage to that retroperitoneal space, or we call it retroperitoneal fibrosis, or thickening or scarring of that tissue. And so we know that endometriosis creates its own nerve supply, because it's got nerve growth factors in it. And so they're destroying these nerves underneath and then causing a whole new type of pain. And so some of these patients, when they're treated that way, end up having something called central sensitization, where their body is rewired to experience pain in a way that those nerves were not originally meant to. And so what happens is those patients, you can treat their endo, or you can even treat their retroperitoneal fibrosis, but until you are able to get rid of all the other pain triggers in their pelvis and then change the way the brain is perceiving that pain again, you're not going to get those patients treated. And so I think one of the main reasons that we get central sensitization is because the disease is either left to grow on its own too long, and that delay in diagnosis comes into that, and or there's too many ineffective treatments that are done, like ablative surgeries, And I had one patient who saw a doctor, and the doctor said, well, you're just going to need to have a surgery every 3 to 6 months. And I think she was not even 20 yet, and she'd had 12 surgeries by this guy. And I think that that's criminal, and that sort of mindset should be completely eliminated from any perspective of treating endometriosis in this country. But to see that, it's very disheartening.
My God, that's mind-blowing.
Absolutely.
Wow.
We've had patients who've had as many as 20.
Oh my God.
Yeah. And unfortunately, patients trust their doctors. They think that their doctor is really smart. They think that their doctor has their best intentions, for them. You get a guy like that who's performing surgeries on every patient, every 3 to 6 months. All you need is 100 patients, and you've got a career. Because you're operating continuously on all those 400 or 100 patients. You're doing 300 or 400 surgeries a year, all at the expense of the patient. And you're not helping the patient at all. And it's very unfortunate that there's people out there like that.
Oh my God. What would that do to you in the long run?
Well, again, I think you'd end up having, the retroperitoneal fibrosis, and then you're going to have central sensitization as well. And now you're going to have a condition that's much more difficult to treat than the endometriosis might have been had you had a doctor who would have done excision the first time around.
Wow, that's crazy.
Yeah.
So what information do you think needs to be more clear to people about endometriosis?
One, that, a lot of young women will go to the doctor, women in their teens, and they'll say to their doctor, I think I might have endometriosis, or I'm having pelvic pain. I think we have to, try to teach doctors that endometriosis is a condition that usually starts in teens, and the incidence is very high. Depending on which theory you believe causes endometriosis, I actually believe that you're born with it. Okay, there's evidence in fetuses that show that they're born with endo at birth. The endometrium itself is different than endometriosis. Endometriosis has its own ability to produce estrogen in its own microenvironment, which endometrium does not. And there's never been any evidence, electron microscopes showing an endometrial cell from the uterus implanting in the pelvic sidewall. Despite millions of pathology specimens, there's not a lot of evidence that retrograde menstruation is the cause of most of patients' endometriosis. So I think most women are born with it, and so recognizing that fact, and the Endometriosis Association suggested in a study that they did that 65% of patients complain of pelvic pain within the first 6 months. I think it may be as much as 80% within the first 6 to 12 months complain of having painful periods. And recognizing that, and if a patient doesn't have improvement on birth control within 6 months, then the next step should be surgery. So that's a very important concept there. Doctors have to do a better job, of course, and not be the reason for that 12-year delay in diagnosis. And then not doing all these expensive therapies without having a diagnosis either. Because if some doctors say, oh, well, I'll put you on Lupron at 16, and if your pain gets better, well, then it's endo. Well, unfortunately, there's other studies out there that showed that about 85% of patients who were on Lupron or other highly suppressive things were found to have endo, despite the fact that they didn't have a response to Lupron. So that means nothing, and it's a terrible test to put patients on because, one, it's expensive and it has a lot of side effects. Some of them can be permanent, and I don't think that it should ever be used as a diagnostic test. I don't think that Orlissa should be used as a diagnostic test either. Those are really things that if anyone's going to use, they should be used as salvage treatments. If you've exhausted every other possibility, then you may want to consider using those things. But even if you look at Lupron only helps about 40 to 50% of patients whose symptoms are other than painful periods. So if they have painful intercourse or painful bowel movements or chronic pelvic pain or backache, only 50 or 40% are going to have improvement in those symptoms. So a doctor who says, well, yeah, you're not getting better because your bowel movements aren't feeling any better. Well, it can't be endo then. So then they end up shipping you off to another doctor, a gastroenterologist, to get another workup, and they come back and they don't find anything, and then you got IBS. And then you're stuck with that label. And then if you have, a good excision surgeon go in and find endo on or near the bowel, you've got an 80% chance that your IBS was because of endo and not because of your, truly being IBS. Again, getting the more appropriate treatments, being quick about moving patients to surgery, I think are very important aspects that we have to kind of hold to, and educating doctors more about endometriosis, and not just gynecologists but primary care doctors as well. So pediatricians, family care doctors, gastroenterologists as well, to question, okay, a woman comes into my practice, I have to ask them, do they have painful periods? Do they have painful intercourse? Do they have other things that would suggest endo? And if they do, instead of just saying you've got IBS, and sending them on their way with a possibly an incorrect diagnosis, maybe refer them back to the gynecologist and say, you may want to think about endometriosis in this patient. And if they're hearing it from another doctor, maybe they'll consider the possibility and put that patient on the pathway to earlier diagnosis. It's important for all sorts of specialties to be aware of that. All the different specialties that endo can manifest with, including, the urologists, including even thoracic surgeons. I deal with a lot of thoracic endo patients, and so they end up, going to the emergency room with either a collapsed lung right around the time of their cycle, or chest pain that never goes away, or is worse during their cycle. And they get blown off for many, many years because no one thinks about the possibility of endo in that situation. I operate on usually about 4 or 5 patients who have possible thoracic endo every month. So that's a huge number when you put it in that perspective. That's about 50 or 60 patients a year, or 1/5 or 1/6 of the patients I'm operating on.
Wow. And yet they say that it's like pretty rare in study.
Well, and I do get more of those patients than a lot of other doctors do, just because we've done a lot of that. And we've been doing it for 11 or 12 years, whereas, a lot of the other doctors who've been following, are starting to do thoracic endo, they've really just kind of gone on the bandwagon lately in the last couple of years because, they've heard, oh, yeah, the CEC, they treat women who have thoracic endo, and it's like, oh, well, I don't want to have anyone else be operating on any of those patients. So they end up wanting to, do it themselves. Unfortunately, the problem with that is that sometimes they'll have a thoracic surgeon who doesn't buy into it. And so they'll end up, having a laparoscopy or a robotically done surgery, and then they don't see much on the diaphragm, and not realizing that most of the disease is on the backside of the diaphragm behind the liver, and they can't see it. And then they get dismissed because the thoracic surgeon isn't going to do a scope on them, and if they had, they would have found the disease. So unfortunately, that is one of the things that we also have to deal with. And just, it's hard to develop a center like we have, because I had to also make the general surgeon believe that these patients are going to do better when we have to do a bowel resection, or we have to, do something to their bowel to get rid of all the disease. Again, it's that concept, well, doing, a fairly radical surgery for something that isn't going to kill someone. It's not like you've got cancer of the bowel. and you can just definitely justify a bowel resection in that patient. But if you've got doing a more complicated or risky surgery for someone who's again got invasive bowel disease, not all general surgeons or colorectal surgeons are going to say that's a reasonable thing to do. But you ask the patient, they're like, yes, by all means, do whatever you need to get rid of my bowel disease so that I'm not in pain every day when I go to use the bathroom or whatever the case may be.
Well, thank you so much for being on.
Oh, my pleasure.
I would love you to be on again. If any of the viewers or listeners have any questions or would like to see you again, drop the comments below and we will set up another interview.
That'd be great.
Thank you so much.
No
Have
problem.
a good afternoon.
Yeah, you too. Thank you so much.
Bye.